diabetes literally affects the person, okay, from head to toe. Okay, there is no organ system that is spared, okay? The ravages of diabetes, from depression, okay, and stroke, to a diabetic foot infection or altered sensation or pain perhaps in the feet, and everything in between. So I hope that gives the listener a sense, okay, of what happens to these patients who develop pain associated with their diabetes.
Welcome to the Pharmacy Quality Solutions Quality Corner Show, where quality measurement leads to better patient outcomes. This show will be your go-to source for all things related to quality improvement and medication use in healthcare. We will hit on trending health topics as they relate to performance measurements and find common ground for payers and practitioners. We will discuss how the Equip platform can help you with your performance goals, and we will also make sure to keep you up to date on pharmacy quality news. Please note that the topics discussed are based on the information available at the date and time of recording. Information or guidelines are updated periodically, and we will always recommend that our listeners research and review any guidelines that are newly published. Buckle up and put your thinking cap on. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. Welcome back to the PQS podcast, where we focus on medication use, quality improvement, and how we can utilize pharmacists to improve patient health outcomes. I'm your host, Nick Dorich, and on today's show, we are continuing our series on diabetes, the impact that has on patients, and how pharmacists can be utilized to improve the care management for those patients. Now, for many, diabetes management is about controlling blood sugar, and it can be related to medication use that manages the aspect of the body, appropriate insulin levels, and or lifestyle modifications. However, there is another aspect of diabetes management that will be a focus for today's episode, and this relates to pain management for patients with diabetes. With that, I'm going to now introduce our guest for today's episode, as he is an expert in both diabetes and pain management, making him a great guest for today's show. Dr. Charlie Ponte is a professor of clinical pharmacy and family medicine at West Virginia University in Morgantown, West Virginia. Charlie, welcome to the PQS Quality Corner Show.
Yeah, hello, Nick. It's good to be here.
Well, happy to have you here. And before we get into our conversation for today about diabetes and managing pain, we need to know a little bit about you. So, Charlie, do you mind giving us a little bit of information about your background in pharmacy and in healthcare and what you do today?
Yeah, I'd be happy to. I wish I could say that I had started in a 50,000 watt radio station, but I can't, even though this is a podcast. But, let me say that I originally, I'm from Connecticut, and I have a pharmacy degree from the University of Connecticut, and also a doctor of pharmacy degree from the University of Utah, and a hospital pharmacy residency at Yale New Haven Hospital in New Haven, Connecticut. I have board certification in pharmacotherapy, advanced diabetes management. I'm also certified in pain education and also in diabetes care and education as well. So most of my career, frankly, has focused on pharmacy education, the training of medical residents and medical students in family medicine, and also really the provision of pharmaceutical care. And I really have been involved in the care and management of people that have diabetes for a long time, and frankly, probably longer than many of your listeners. I've been doing this since the early 1980s, which is a long time. So aside from my academic and educational responsibilities, I've kind of morphed into this hospitalist position. Much of my clinical experience has been both in AM care as well as acute care in the hospital setting, but I kind of gravitated to more of a hospital-based practice, acute care, and I'm really a member of a ward team for the family medicine service at a large tertiary care teaching hospital, which is Ruby Memorial Hospital, which is affiliated with West Virginia University and the Robert C. Byrd Health Sciences Center. So I have pretty much an inpatient practice, but I also have an outpatient practice in a twice weekly discharge clinic. So I guess I wear lots of different hats.
That certainly sounds to be the case there, Charlie. And actually, really interesting. I want to ask you first because you'd mentioned a term or a descriptor that not everyone may know, and I want
Right.
to address this before we go further. You'd
Yep.
mentioned being a role that's kind of in a hospitalist.
Right.
What does that mean? What does that signify?
Well, when I refer to the word hospitalist, it means that the primary emphasis of my practice or the focus is with acute care in hospital patients. So I see patients in the hospital setting. Normally, if you're a family medicine patient and you get sick and you are sick enough to be admitted, then I'm the person you see. In fact, I'm the person that you don't want to see because that typically infers that you're sick, or at least you're sick enough to be in the hospital. So I think a hospitalist tends to be someone with a primary practice with an inpatient acute care kind of setting, as opposed to a traditional outpatient or, let's say, community-based practice.
Excellent. Well, thanks for adding that description for us. It's helpful just for our audience to understand where you're coming from, your
Sure.
area expertise, and how that ties into patient care. Now, Charlie, before we get into today's questions, we're going to stop for a moment so our audience can hear the breakdown.
Now it's time for the breakdown. As Quality Corner show host, Nick will ask 3 main topic questions. Our guests will have a chance to respond, and there will be some discussion to summarize the key points. This process will repeat for the second and third questions, which will wrap up the primary content for this recording. After that, expect to end on a closing summary, usually containing a bonus question. Now that we have described the process, let's jump into the questions.
Pharmacist Letter is offering continuing education credit for this podcast. Please log into your Pharmacist Letter account and look for the title of this episode in the list of available CE courses. I'm Nick Dorich, and our guest today is Charles Ponte from West Virginia University. Neither of us have anything to disclose for the purposes of this CE. All right, Charlie, we're back and we're ready to go into the questions for today. And to get us started, I want to cover diabetes. More specifically, I want to cover the pathophysiology of diabetes, or as the clinically relevant term, diabetes mellitus. But more specifically, we want to cover what is diabetes, but how does that also lead to pain and discomfort for patients? We often think that it's really, again, about that management for glucose or blood glucose, but we as clinical practitioners know that it can develop to something more than that, and that's something we want to start with. So I'll hand it off to you at this point, Charlie, but diabetes and how it leads to pain, discomfort for patients, what can you tell us?
Well, I think most of our listeners, most community practitioners are probably going to deal mostly with people that have type 2 diabetes. And, type 2 diabetes is the most common form of diabetes. It's a condition that really has a number of defects associated with it. And when I was a student and when I was taught, it's funny, diabetes, there were basically 3 defects. Okay. There was a defect in beta cell function in the pancreas, which is, involved in the manufacture and secretion of insulin. But not only that, but also tissue resistance. The tissues, muscle, and fat are resistant to the action of insulin. And then thirdly, the liver made too much excess glucose. So those were the 3 sort of primary defects. Now we have well over 11 different defects. And I think most of our listeners are obviously probably quite well versed in diabetes and its metabolic consequences. But of course, one of those consequences of the metabolic derangement that you see not just in glucose metabolism or glucose handling, but just in the overall metabolic defect associated with diabetes is the development of pain in these patients. And so when you talk about pain associated with persons who have diabetes, you're really talking about, for the most part, neuropathic pain. Neuropathic, neuroempathic, there's some kind of disease or some kind of dysfunction with nervous tissue or with nerves, and that's kind of the root of neuropathy. So this neuropathic pain basically infers that you have damaged nerves, okay, in the body. And that's very commonly seen with people who have diabetes. And I'll get to some of the statistics in just a second. But let me give you some common examples of neuropathic pain in general. People that have had shingles, okay, can develop what's called post-herpetic neuralgia, a very chronic kind of pain, debilitating, kind of problem, which can follow a bout of shingles. But also, your viewers and your listeners may have some experience with individuals who have what's called phantom limb pain. They've had an amputation, but for all intents and purposes, they still have pain as though they still have a limb attached to that particular body part, and even carpal tunnel syndrome, especially with today everybody on their cell phones and on their computers and their tablets. Those are all kind of examples of neuropathic pain. Now, specifically, if we discuss patients who have or people who have diabetes, generally what happens with neuropathic pain is that it arrives from peripheral nerve damage, and it's called a peripheral neuropathy, okay? And as I alluded to a second ago, diabetes causes about 30%, which is, 1 out of 3 people who have neuropathic pain, the cause is diabetes. So uncontrolled or poorly controlled diabetes can result in peripheral nerve damage and can actually affect upwards of half the people who have diabetes. So neuropathic pain is very common in folks who have diabetes. And frankly, you may ask, or the audience may say, well, what causes this? I wish there was a simple kind of all-encompassing, unifying kind of cause or perhaps theory, but really it comes down to a number of issues. One of the issues that's been identified is as dysfunction with the mitochondria. Think of the cell having to have an energy source for its function. It's kind of like putting a little battery in the cell. Well, the mitochondria are responsible for the energy generation in the cell. So there's myocardial dysfunction in nerve cells. Okay, there is thought to be oxidative stress in those cells as well. And don't forget, people that have type 2 diabetes, and if they have neuropathy, they invariably have small blood vessel disease that affects nutrient delivery to that cell, blood flow to the cell. So ischemia or reduced oxygenated blood to the tissue could also be responsible for this neuropathy that you see in people who have diabetes. And even there's been some suggestion that the repair mechanisms of the cell are deranged, okay, in folks who have diabetes. And all of this kind of put it into for the lack of a better analogy, put it into a mortar and pestle, kind of mix it and titrate it, and what you get is dysfunction in nerve signaling pathways, and in many cases leads to pain. So I think it's fair to say it's a complex process, or the pathophysiology of neuropathic pain is not simply related just to altered glucose metabolism or high blood glucose concentrations. It's multifactorial, okay? And, I teach this too with anybody who's willing to listen, that, diabetes literally affects the person, okay, from head to toe. Okay, there is no organ system that is spared, okay, the ravages of diabetes, from depression, okay, and stroke to a diabetic foot infection or altered sensation or pain perhaps in the feet, and everything in between. So I hope that gives the listener a sense, okay, of what happens to these patients who develop pain associated with their diabetes.
Yeah, Charlie, it's an excellent description, and I do have one quick follow-up question here for you before we go into the next topic.
Okay.
And you had mentioned that this is going to be this pain, that this discomfort is something that virtually every patient with diabetes is going to be experiencing at some point. When it comes to a new diagnosis for a patient, what is that expectation? With a new diagnosis, there's always a lot to understand, and that can be very shocking to someone anyways. What's kind of the approach to helping patients understand with that diagnosis, how that pain can be manifesting?
Well, I think first of all, I just want to say all patients who develop diabetes, either type 1 or type 2, are not going to develop neuropathic pain. It's about half. Okay. So it's kind of hard to, and the problem is you don't know which half, okay, are going to develop the neuropathy. I think what you tell patients and leave up front with a new diagnosis is that you can avoid, okay, hopefully avoid the complications if you pay attention, okay, to blood sugar control plus all kind of the other facets of control that are equally important, okay? Meaning you have to pay attention to lifestyle modification. You have to pay attention to some of the dietary manipulations, okay, especially for people that have type 2, which most of pharmacists, physicians, other providers are going to see compared to the person who has type 1 diabetes. So I think what you try to do up front is prevent this from taking place as opposed to trying to deal with it after it happens. Now, that being said, okay, prevention is worth a pound of cure. And it sounds like a cliche because it is. It's just that even though some patients have good glycemic control, it's possible, okay, to still manifest complications, just like it's possible to have a patient totally out of control and have limited complications. I wish I could have a magic crystal ball or a wand, okay, to say, well, you're the kind of person who's going to develop, you're the kind of person who won't, okay? I think the key is to try to instill in the patient up front the necessity to get on top of it as soon as one could, using all of the tools that are available to treat people that have diabetes. And that's the educational piece, and that's the therapeutic piece, okay? And that's the lifestyle piece and the nutrition piece. And it all has to work in kind of concert, in unison. And you have to have, hopefully, okay, the person with the disease has to have a support structure in place, okay, that can facilitate all of this. And frankly, one of the champions of these folks, it should be and is the pharmacist. So I hope that kind of gives you some insight into maybe how to approach a new diagnosis.
Yeah, that's absolutely a key point there. And it's a fine balance, right? Because you want the patient to be informed, but at the same time, there's a downside to giving and informing the patient of that worst case scenario, because some people may not understand that this is what it could be as worst case, but that's not always going to be the case. But Charlie, I do want to move to our second question, and it actually goes into how you as a provider, but also with the patient, understand this. And I want to talk about that neuropathic pain management. So, you as a provider, you're working with a patient, and they've had some complaints, or they have some changes in their medical status, or just kind of how they're feeling. When it comes to this neuropathic pain management, how is that identified? How is that diagnosed? And then from there, how do you manage it?
I think generally what happens is the person complains of symptoms. Okay. And that could be the person says, my feet burn. It's like taking a hot poker, okay, and searing the skin. They may have cramps. They may have sharp pain, perhaps. They may have what's called, and I'll define those for the audience. It's called allodynia, which means it's kind of an exaggerated response, okay, to what should be a not painful stimulus, okay? Example, if I take a feather and I brush your cheek with it, okay, well, obviously it's going to feel like a feather, But a person who has allodynia, it may feel like sandpaper. It may feel like razor blades. Okay, so it's an exaggerated response. Okay, and that's how in other words, the person says, I can't even keep a sheet on my top of my foot because of the discomfort and the pain associated with it. But they may have throbbing, they may have tingling, the variety of sensations. So, and it's very common that the patient complaints occur in the feet, okay? And generally, the pain tends to get better at rest. Okay, but it could even be worse when they're lying flat in bed at night. And sometimes if the person gets up, or the person who is experiencing this type of pain, if they start to walk, it may actually improve. So there's a number of kind of screening tests that someone could use. Now there are sophisticated, EMG, types of studies and other approaches. But a community pharmacist is an example, someone who is involved in medication therapy management or diabetes management with maybe a physician or other kind of provider. There are simple tests you could do, a tuning fork to assess vibration sense, pinprick. Okay, you could do what's called the Symes Weinstein monofilament test, which is a 10-gram. It's like a piece of fishing line on a little handle. Okay, and then you place it and you push. Okay, this monofilament until it bends, which implies 10 grams of pressure at various points on the top of the foot, bottom of the foot. And if they have lack of sensation in different points, or perhaps total lack of sensation, that certainly puts them at risk that they are having a sensory neuropathy. They could develop pain, they could develop ulcers, they could develop infections. So I think there are some sort of common and easy to do tests. So once that diagnosis is made, then I think you start thinking about non-drug and drug treatments that could potentially, affect the progression of that neuropathy, or perhaps, in some cases may actually improve based on the modality that's chosen. So I think those are some approaches, to trying to sort out if a person has that kind of a problem. But generally, it's a patient complaint. It's going to be some kind of discomfort, pain, which then one's going to have to pursue either simply or more sophisticated approach.
So, Charlie, this does sound like there's certainly opportunities, and you had mentioned with it, there are ways that pharmacists can help patients understand this. And some of these tests, the patient may not come up to the pharmacy in the middle of an aisle. These may be tests that are done in a counseling room. So there may be kind of other locations or better places to have. But I do think it speaks to the importance of the pharmacist continuously having the conversation with the patients on how are they managing their diabetes? Are they noticing any changes with their body? And that can often prompt it. Well, have you been to your specialist? Have you spoken recently with your endocrinologist, or perhaps some providers that are more adept with those parts? But the pharmacist is still incredibly important with this situation. And, with that, the treatment part of it, how that does get managed is going to be incredibly important. So I'll move us to our third question, and it's going to be just about that. With identification, with management, we're then talking about how the patient is going to be managing their pain, their discomfort. What treatment options are there? Pharmacologically, what options exist? What options are most common? And then, of course, we are pharmacists. We talk about medications, but there's always lifestyle changes that could potentially have an impact as well. In a case like diabetes, it's related to reducing that A1C. But what are the recommendations? Are there guidelines on how this should be managed?
Yeah, I think there are a variety, as I alluded to, of non-drug and therapeutic or drug treatment options. I think the first thing, though, before you kind of go down the path, okay, of drug treatment, is to try to improve glycemic control, as you mentioned. Try to have the person adhere to lifestyle, diet, physical activity. Try to avoid or limit alcohol. Anything that could contribute to a neuropathy, and that, frankly, includes stopping smoking. Now, the problem with that, okay, is since we're in this kind of era of evidence, okay, based practice, the evidence that supports these non-drug modalities is fairly weak, okay, and not terribly robust. Now, that being said, if I may digress for 1 second, I had a patient some years ago who had significant peripheral neuropathy. He could not take a washcloth and wash his feet on the top because they hurt so much. And it was early in the use of insulin pumps. So we put the person on an insulin pump, and we got better glycemic control after, I guess 2 or 3 months of improved control. For the first time in a long time, okay, he could literally take a washcloth, wash the top of his foot, and he had less discomfort. So I'm not going to say never say never, okay, but I think in 2021, most of the management is drug treatment, frankly, as opposed to non-drug. And frankly, the evidence behind some other approaches like acupuncture and massage therapy and biofeedback, yeah, it may have some benefit in some patients, but again, I think the evidence is somewhat not, again, robust. So what are we left with? We're left with generally using anti-epileptic drugs and antidepressants. Those tend to be the two major classes of medications used to treat diabetic neuropathy and the pain associated with that. The two drugs that are FDA approved are pregabalin or Lyrica and duloxetine or Cymbalta. Okay, now we also use Neurontin or gabapentin. If you look at the efficacy of pregabalin, it's maybe 30 to 50% will have some benefit, not 100%. And I think anybody who's a pharmacist knows that no drug treatment is 100%. But 50% could be significant from a lifestyle sense. Now we can use venlafaxine also as an option, and even valproic acid has been used. Some patients you may see even on older tricyclics, and even a drug like carbamazepine or Tegretol, has been used to treat patients who have diabetic peripheral neuropathy. I think one has to use caution with these drugs, especially in older patients. You have to be mindful of drug interactions, monitor for adverse drug effects. And again, I think, one has to titrate appropriately and monitor appropriately. The thing, too, you got to remember is patients who have even diabetic peripheral neuropathy, that's a chronic pain state. As such, okay, there are a lot of psychological baggage that comes with it, including depression. And if you are depressed and you have diabetic peripheral neuropathy and you have that kind of chronic pain state, the depression itself can exacerbate the pain. So it begs that you need to treat the depression as well. And in some cases, the newer, the second generation antidepressants, can be very useful. And one last pearl, okay? Don't discount the effects of anti-diabetic medication and how it could affect neuropathy. Classic example, about 1 out of 5 patients after about 5 years on metformin could develop a B12 deficiency, okay? And that, in of itself, may have, some effects, not so much on perhaps neuropathy, but, one sometimes thinks that, there are no other metabolic consequences, other than glycemic control associated with, anti-diabetic medications, but that frankly is just not true. So always be on the lookout for how their current drug treatment and even other drugs could perhaps influence the neuropathy and the pain associated with it.
Excellent. Now, Charlie, I do have one question for you as well as a follow-up here. You'd mentioned for some of the medications that could be used for that neuropathic pain management, such as the anti-epileptics. For those where there may be, and those had FDA indications for this type of pain management, correct? Now,
Right.
with those, and for that specific pain management, is dosing, frequency of dosing, is that going to be different than, say, other clinical indications? Is, a pharmacist getting a prescription, are they going to necessarily notice that that it's for that pain management versus other uses, just based on how the medication is dosed?
Frankly, unless it's noted on the prescription, or the pharmacist knows the patient and their history. If they're titrating the dose, then no, then all bets are off. You may not know that it's specifically being used to treat neuropathy. So I think it sort of begs knowledge. And if there's a question, then they should contact, the provider, because I mean, in general, especially with the older medications, dosing is akin to treating epilepsy as an example. We used to use, Tegretol or carbamazepine. It was dosed no different. Okay, the tricyclics now, as an example, might be, you may see a patient on occasion with it, not the drug of choice, not advocated, but the doses tend to be a lot less than what you would see to treat a person, let's say, who had depression. Okay, so I think one has to, just if there's ever a question, I guess the best way to say this is, contact the provider and try to find out what's going on with that, as far as the doses themselves go, if that helps answer the question.
Yeah, it does. And it's contact the provider, right? Or, ask
Yeah.
that question, but also ask the patient, right? If you're the
Right.
pharmacist that's going to
Yeah.
be managing that patient's medication, some cases, and for an anti-epileptic, as you made a mention to that can be an important conversation for that pharmacist to have with the patient on what that patient is expecting, or specifically what they're expecting with the use of the medication, right?
Right.
It's stopping seizures specifically versus the pain management. That's going to be two different expectations for a patient. So helping the patient understand and confirming what the patient's expecting is also helpful for your pharmacy staff, so that when they are following up with the patient, it's clear expectations for managing that disease and hopefully ultimately alleviating those concerns and that underlying issue that the patient has. So great response, Charlie. Really appreciate that. And actually, Charlie, with that, we're wrapped up for today's conversation on diabetes, neuropathic pain management. And as expected, your expertise and description for that combination, diabetes and pain management, came in very handy. This was certainly a good reminder for me, a good crash course again on this topic. So it's always a good part for me to learn about these topics. And your approach here to it was very insightful, very helpful, and gave us a lot of tidbits to take away for both myself, but ultimately for our listeners. So I really do thank you for that. Now, for our listeners that are routinely checking with the PQS Quality Corner show, that we don't let our guests go without asking them a final question. And it's not always related to our topic of the day, but it might be. And Charlie, I'll leave that up to you. But our question is, what have you been working on in this last year and a half, 2 years? What have you been working on to further develop or improve your skill set? So it might be related to how you work with patients and pain management. It might be something completely different, but what's been your new development?
Well, I have two. That's a two pronged kind of response. Okay, one, I've learned how to navigate COVID, and I've learned how to stay alive. Okay, in the last year. Okay, that's one. But to be more in tune with the podcast, I learn something every day, okay, when it comes to trying to improve my skill set. And I do that by continuing to practice pharmacy in the acute care setting. And because I have the fortune of being a teacher and being around students and medical residents, pharmacy students, medical students, they teach me something every day. Okay, so I have this ongoing, continuous faculty development program by virtue of what I do every day. So, and I'll leave you with two quotes, and I don't know where they came from, and I won't take credit. But remember, you learn by doing, right? That's how you learn. You have to do it. It's nice to hear it, but until you do it, it doesn't make sense or it doesn't stick. Plus, teaching helps you understand. Okay, if you can teach something, that means you know it and you understand it. Okay, so I think all of us can learn something just by being aware. Okay, and look and listen.
Excellent. Well, Charlie, thank you for those final couple of reminders. For us, certainly elements that all of us can take into our daily life and our daily practices. Now, I did have one actual final question for you, Charlie, and that is before we wrap up. Folks may be interested in learning more from you, or they may be interested in following up with you about our topic of the day as related to diabetes and the pain management. So, final question: if someone wants to follow up with you, ask another question, what's the best way to contact you?
I think the best way is email D as in Dennis, Ponte at hsc.wvu.edu. That's the easy way to get me. Just email.
Excellent. Well, no problem with that. We'll make sure to include it. And Charlie, again, thank you for appearing on the show today. A lot of great information. And for those students, whether it be in the pharmacy or the medical practice, if your classes are anything like your appearance on the podcast today, they're going to be full of information and entertaining. So they are some lucky individuals there. But appreciate having you on the show. And for our listeners today, that is all for this episode, but we always have some final messages for our listening audience. So make sure you subscribe to our podcast. And if you have a question or topic, please let us know. Similarly, you can, if you would like to suggest a topic for the show or come on the PQS Quality Corner Show, we would love to hear that. You can DM us on Twitter at Pharmacy Quality or by emailing info@pharmacyquality.com. Now, with that, I again appreciate you listening to the Quality Corner Show. And there's one final message from the PQS team.
The Pharmacy Quality Solutions Quality Corner Show has a request for you. Our goal is to spread the word about how quality measurement can help improve health outcomes, and we need your help in sharing this podcast to friends and colleagues in the healthcare industry. We also want you to provide feedback, ask us questions, and suggest health topics you'd like to see covered. If you are a health expert and you want to contribute to the show or even talk on the show, please contact us. You can email info@pharmacyquality.com. Let us know what is on your mind, what we can address, so that you are fully informed. We want you to be able to provide the best care for your patients and members, and we wish all of you listeners out there well.